Welcome to School-Based Practitioners supporting students with mental health needs in the school environment. We still have people joining us. So we're supporting students with mental health needs in the school environment. We're welcoming Dr. Perry Rosen from OMSAS this morning, and we're so glad you're with us. My name is Gina Spicknell-Cook, and I'm an educational consultant with Patton. And I'm joined with several colleagues today, Dr. Erica Caruter, Mr. Scott Simo, Kate Parker, and Shonda Talene. And I'd like to just give a little bit of an overview. We will be having a 15-minute break. This session goes from 9 till 11:15 and is being recorded. In order to receive credit for today's session, participants must be logged in on your own device, and you must stay for the duration of the session. A code and survey will be provided at the end of today's session. Live transcription is enabled, so if you need to see the transcription today, just enable it by clicking Live Transcript button on your screen. For those of you seeking NASP CPD, that will be processed separately, as will Act 48. Now, I'm very happy and excited to introduce Dr. Perry Rosen, consulting psychologist for the Office of Mental Health and Substance Abuse Services. Thank you, Perry.
Thanks, Gina, and thank you to Patton for hosting this webinar this morning. And good morning to everyone. I know that this year so far has been a lot busier than many of us could have ever anticipated. So I just want to thank you all for taking the time out to attend this presentation this morning. I also just want to thank everyone for all of your ongoing efforts in terms of working to support students with mental health needs in your settings. I know there's a lot of expertise here today, and all of you are continuing to work as advocates for your students with mental health needs, as well as for their families, and also for your own roles really as mental health professionals within the school environment. So very grateful for that. This is the mission statement for the Office of Mental Health and Substance Abuse Services, so I'll leave this here for just a moment. And in terms of our objectives for this webinar, the first objective is really to describe the essential components of comprehensive school mental health approaches and how they align with multi-tiered frameworks. The topics that are being discussed today are going to likely be very familiar to all of you. Some of you may be pretty well versed in some of these areas already, but we really want to think about framing these efforts within the context of comprehensive school mental health, and also thinking about sustainability of school mental health efforts as a priority. Some of the information that is going to be shared will come from various national resources, from state initiatives, and also some of the content was drawn from the National School Mental Health Curriculum, and you'll see that noted on different slides. That curriculum is free and accessible, so it's something that you may also be able to access within your school settings. And it was developed by the Mental Health Technology Transfer Center and also the National Center for School Mental Health, really to help schools understand the key components of what comprehensive school mental health systems are, and also the importance of engaging in strategic planning. The second objective is to summarize key practices and approaches for identifying, supporting, and responding to students with mental health needs in the school environment. Most of this presentation will focus on the more targeted and selective approaches and considerations for the infrastructure that can support that. But I am going to start off with some foundational considerations. Also, I'm going to briefly touch on some of the universal approaches as well. And then finally, I plan to share a wide range of resources related to student mental health at school. And in the interest of self-care, just know that you will have access to the slides, so you don't need to note all of these down. There's a Padlet that's been developed, and all of the resources are linked on these slides should you want to access them in the future. So in terms of starting by talking about our baseline for youth mental health, this is really where we were in terms of youth mental health prior to the COVID-19 pandemic. So we've known, especially in our profession, we've known for a while that mental health problems among youth are very common. About 1 in 5 youth have a diagnosable mental health condition. And also an estimated 70% of children have experienced some type of physical or emotional trauma. Even before the pandemic, we had already been seeing an increase in both the prevalence and the severity of mental disorders in children and adolescents. And these concerns, of course, as all of you have seen firsthand, have only continued to grow during the pandemic time. Childhood and adolescence as well are both key developmental periods for the onset of symptoms. So we do know that about 50% of all mental health conditions have their onset by age 14, but there is often a very significant delay from the onset of symptoms to when youth are able to get any kind of support or treatment. And so as we know, when that happens, symptoms may worsen or intensify, and that does often lead to a range of negative or adverse outcomes that we often see playing out in our schools. Also, of the students that do receive mental health supports or services, a vast majority do receive those within the school setting versus in other community settings. So again, when we think about addressing some of the disparities that we're seeing in access and quality to mental health care, we really need to think about our schools as a primary context for that. Suicide as well, and again, this is before the pandemic, has been a leading cause of death for youth, and we've known that also for quite some time. We've seen suicide rates increase significantly over the past 2 decades, and especially since the mid-2000s to the present. But we also do want to recognize that this isn't an epidemic of suicide. We know that a suicide death for a youth is still rare, but suicidal thoughts and suicidal behaviors do tend to be more common, as you're seeing from this data. And so this is what is reflected from our Pennsylvania Youth Survey. Most of you are familiar with this, and it's administered every other year to students in grades 6, 8, 10, and 12. And we actually were able to pilot with 4th grade for the last administration that took place this past fall. But it gives us a wide range of information about mental health concerns, as well as substance use concerns, and all of the different risk and protective factors that impact youth within their schools and communities. So looking at these numbers here, it really does help underscore why we need to be thinking about suicide prevention as part of our comprehensive school mental health efforts. And also makes us think about how all of this has been impacted by the pandemic. So we will be finding that out shortly come this spring when we get the results of our 2021 PACE survey. One other thing I do want to mention about this data is that in general, not just with PACE, but even in our national data, we have really had some significant gaps in terms of looking at special populations or subgroups of youth that have had concerning trends. We haven't historically in research with our national data or even with our state data really been looking at disaggregating that to look at these trends. But recent national studies have brought to the attention that suicide rates are increasing significantly for our Black youth, including increasing rates for Black elementary school children. And rates for this population have been increasing faster than any other subgroup. So as we start to look at data from the pandemic, we know that a lot of this is still limited, a lot of this is still emerging. There have been a lot of questions and concerns about the suicide rates in the pandemic, especially. What has come out so far, I'll just provide little snippets here and there because again, we don't have the holistic picture, but the CDC did release provisional data that actually showed that we saw a decrease overall in our suicide rates in 2020. And that was down from 2019, which was also the first year of decrease in more than a decade when we look at our overall numbers. But as you can see, there are some really concerning trends that are arising within certain populations. I will note that the asterisk notes that this finding was not statistically significant. All of this information is still provisional because we don't have the final counts from 2020 in yet. But again, concerning trends that we need to be looking out for. So of course, that while overall rates did decline, that we have seen these rates rise among Black, American Indian, Alaska Native, and Hispanic males. Also, we just heard last month that the CDC released data that suicide rates rose among youth and young adults in this time frame. We really, again, want to be mindful of not utilizing terms like epidemic, especially when we're talking about youth suicide. As in youth in particular, suicide is a low base rate behavior. So even small fluctuations do tend to have a significant impact on the rates. But in general, we do want to be watching for these trends very carefully. And one of the biggest takeaways that we are seeing is that these issues are most impacting those populations that already have been disproportionately impacted by the COVID-19 pandemic. And mainly that is our BIPOC communities. Also what you're seeing here, so we not only have data on suicide death rates, but also on mental health crises and suicide attempts from emergency room data. So emergency room visits for people of all ages actually declined during the start of the COVID-19 pandemic. And this makes a lot of sense if we think about where people were at. We had lockdowns. Nobody was wanting to go to emergency rooms. There was a lot of fear around the contagion of the virus. There were stay-at-home orders. So it makes sense that those visits did decline initially, but we did see visits then increase after that. For emergency department visits, especially for suspected suicide attempts, that started to increase in adolescents starting in May of 2020, so a couple months in, and especially and very significantly for girls. We also had studies that compared visits later on in the pandemic to earlier timeframes and found significant % increases for mental health related visits in general, in addition to those for suspected suicide attempts. So a lot of issues going on, of course, and perhaps none of this is surprising to many of you, but we have data now that is starting to confirm what a lot of us have been seeing play out in our settings. I do also want to highlight some findings from the Trevor Project. This is a national organization. They're focused on supporting LGBTQ+ youth, and they do an annual survey. And so this is just some snippets from their 2021 survey. You can find the full survey results if you go to their website. But this, they surveyed more than 35,000 youth. They were between the ages of 13 and 24, and nearly half of the sample that responded were also youth of color. And overall, the mental health concerns among this population are much higher than the general population. This is something that we knew prior to the pandemic time. Also, 40% of all LGBTQ respondents reported seriously considering suicide in the past 12 months. And you see that this rises to more than half if you're looking at those yellow bars on the right, where when youth are identifying as transgender or non-binary. But what's really helpful and important here is that since this survey was from 2021, it was conducted during the pandemic. And so it gives almost some real-time data in terms of the experiences of these youth as they were grappling with COVID-19. And so you can see that there are significant concerns about anxiety and depression being reported. And in general, majority of these youth reported that they felt that their mental health was poor, either most or all of the time during the pandemic. Also, just want to highlight a few key risk factors, risk and protective factors. We'll talk about some of these a little bit more in a bit, but the majority of these youth said that the pandemic made their living situation more stressful. It also impacted their ability to express their gender identity or sexual orientation. But at the same time, we know that there are some really key protective factors that we can be thinking about in our schools in terms of youth that say they had their pronouns respected by most or all of the people in their lives. Those youth have reported attempting suicide at about half the rate of those that did not have their pronouns respected. As well, having spaces that are affirming of their gender identity or sexual orientation also was related to reports of lower suicide attempts. Everyone is probably familiar with Safe to Say Something, and so just to highlight some of this information, what we're seeing in terms of these trends really has not changed since its inception. And so Safe to Say Something, most of you know, is overseen by the Office of the Attorney General. It's an anonymous system for reporting tips about school safety concerns, and really kicked off because there were a lot of concerns at that time about school shootings and violence towards others. But what we have consistently seen in our Safe to Say Something data is that the primary tips coming in, not surprising to many of us, are focused very heavily on those mental health concerns. And so this did stay the same and consistent during the pandemic, even though we did see a reduction overall in the number of tips coming in. Again, likely because students were a little bit more isolated in their homes, not necessarily in the schools, maybe not seeing things as much as they otherwise would have. I also just want to briefly share, so the Child Mind Institute compiled a report on what we know about the impact of the pandemic on youth mental health so far, with that caveat. And they had partnered with the Morgan Stanley Alliance for Children's Mental Health to do a national survey of adolescents, ages 15 to 19. And this was focused on aspects of their transition to what they were calling this new normal. So they asked teenage participants, how concerned are you about each of the following when thinking about returning to your regular activities that you used to do before the pandemic? And as you're seeing on this slide, there are clear racial disparities regarding perceptions of this transition. So Black and Hispanic adolescents are more likely to have concerns about all of these indicators: social anxiety, falling behind in school, mental health challenges, family struggles, coping with trauma, all of these. And so that's a real significant trend across the board coming out of this survey. On a positive note, about 40% of teens also said the pandemic increased the number of conversations that they felt like they were able to have with others about mental health. So it is opening this window, it's opening that door and those pathways to be talking about our mental health. Additionally, most youth, despite reporting challenges and concerns, did say that they felt hopeful that they would be able to rebound from challenges of the pandemic. So again, just speaking to the resilience, the natural resilience that our youth do have. So that was really just a snapshot of some of our data, and I've been alluding to some of the risk and protective factors. We also call these social determinants of health and mental health. So all of the conditions that we're born into, that we live in, through which we grow and work and play, and our own lived experience, and also the data and research that has come in from the pandemic is showing us overall that not everybody is being impacted in the same way. So also just related to some other findings that came in from the Child Mind Institute, they also focused on some of the indicators that are most significant in terms of how the pandemic is impacting mental health in youth playing forward. So one of the most significant indicators when they consolidated the research, and I just cited the Morgan Stanley study, that was one piece, but some of the other information that they were able to pull out of the data so far, one was that the factor that was most closely correlated with youth mental health outcomes coming out of the pandemic was a child's mental health in the 3 months prior to the pandemic. So that's really important too. And as professionals in schools, you might be thinking about those students that were already on your radar, what you saw in them prior to the pandemic, and if you're actually seeing this play out now. Another big finding from the Child Mind Institute's report, especially in thinking about the social determinants, is that mental health outcomes were also related to other factors at the family and community levels. So one example of that, for instance, was that children that were living in financially unstable households or experiencing food instability during the pandemic, those students also experienced worse mental health outcomes than their more financially secure peers. So one thing that this report concluded overall is that promoting financial stability, supporting food security, all of these pieces about the child's environment and some of these basic needs is as critical as ensuring that children have access to mental health supports and mental health care. And prior trauma was also, of course, something that was found to play an important role in terms of the impact of the pandemic on students that may now be experiencing longer-term outcomes. Just one more thing to mention, and I had talked briefly about resilience, but we do know that as far as crisis situations, including crises that affect schools, most students and staff will be able to get through a crisis without intensive interventions and with their natural support systems. So we want to just remember that that recovery does tend to be the norm, and that we do want to avoid treating everybody as if they're traumatized. In doing so, we can somehow or sometimes inadvertently cause harm. And so what we really want to be turning to and focusing on is creating those safe and supportive learning environments, and really focusing on how we can build wellness of everybody within our school. So just to briefly highlight, Pennsylvania has been placing a growing emphasis on youth mental health through legislation. These three are not the only relevant pieces of legislation, but they're just ones I want to mention in terms of helping guide some of our mental health efforts in schools. One of Pennsylvania's first efforts toward this, which by now most of you are well familiar with, is Act 71. And that calls for those policies and procedures, the training for educators in grades 6 to 12, which is something we really see as a minimum. And of course, that student education piece, which sometimes is overlooked in this legislation. I will say that through the Garrett Lee Smith Youth Suicide Prevention Grant and our statewide suicide prevention organization, Prevent Suicide PA, there are a range of resources out there to support schools in meeting a lot of these requirements. Also, we have Act 44 of 2018. This was a pretty large piece of legislation. Several amendments have come through since then, but this is what followed the Parkland school shootings and really helped to bolster school safety efforts in schools, which were not only identified as physical safety measures, but also measures for psychological or emotional safety. And so they put out grants, they established the Safe to Say Something protocol, and they also require schools to assess their physical and psychological safety within their school environments. And that includes assessing their behavioral health, assessing their SAP teams, and also assessing school climate. And then Act 18 really brought in this emphasis on trauma and added language about trauma-informed care and practices in schools. It helped lead to the development of a model trauma-informed plan for schools to utilize, especially in applying for funding to implement trauma-informed practices, and added some additional training requirements for school personnel. And then also that last piece that you see there is taking effect this school year in terms of the new requirements for threat assessment teams. So I have mentioned this idea of comprehensive school mental health systems. And really what this is, it's this framework or this infrastructure for providing the full array of supports and services and promoting positive school climate, social emotional learning, mental health and well-being, while reducing the prevalence and severity of mental illness. These systems are built on a strong foundation of partnerships. And so these are both within the school setting and external to the school. They really rely on district and school professionals that are foundational to these partnerships and really to these systems in general. And it's also focused on assessing and addressing the social and environmental factors, or that context piece that impacts health and mental health. So when these systems are effective, they really contribute to improved student and whole school outcomes. So that's really important to bear in mind. Things like increasing student engagement and connectedness, even better academic outcomes, fewer special education referrals, and many other important outcomes. Despite, however, the rationale for schools as a viable setting for the provision of mental health supports and services, we also know that historically schools haven't always been equipped for this type of work. And first and foremost, and no shock to anyone on this call, but our shortages of school mental health professionals is really a significant concern and a potential barrier to some of this work. We have seen ratios that far exceed the national recommendations, and ultimately this leads to role restriction, as well as a lack of ability to prioritize and fully address student mental health needs at times. A lot of times this makes us feel helpless, where we're pointing our fingers at other systems or we're pointing our fingers at families. And then of course we start to see this tipping point where our schools end up being focused more on putting out fires and responding to crisis than thinking about the prevention efforts that we can be focused on. So what we're ideally trying to work toward with this is that continuum spanning from that mental health promotion and prevention to early identification and intervention, and then to crisis response, support, and treatment efforts. So as has been mentioned, or maybe this has been implied, we know that it's critical to think about operating under or within the context of a multi-tiered framework. And this helps to ensure that we're more systematically identifying student needs and monitoring progress. It also reinforces this idea of mental health for all, and that it's not just those students over there that need this help. And it helps us to reduce the bias and subjectivity in terms of which students actually end up receiving support. There are a bunch of models that are out there in terms of what school mental health can look like across the tiers. But in general, the first tier, we're talking about universal mental health promotion. This is for all students in the absence of a mental health concern or with, right? And then we also look at students at tier who have needs at the tier 2 level, so students that may be at risk. And at tier 3, we're thinking about identifying students that have known concerns, working and supporting those students. Perhaps those students have a mental health diagnosis, but not necessarily. But regardless of the concern, these are students whose needs do have a clear impact on their daily functioning. And many schools in Pennsylvania are working toward these frameworks, but also know that as I talk and use this language throughout the presentation, it's not the case that you do have to have formal MTSS structures in place in order to think about delivering services and supports in this manner from a tiered standpoint. So again, whether or not you are doing this in a formal way, it's really a mindset in terms of how we're viewing the supports that we're implementing, from things that we are putting in place for all students to some students to a few students that may be in need. To turn to the foundation, so I had mentioned that the majority of this presentation will be focused on more of the advanced tiers, but it's difficult to talk about that without first laying out, what are the foundations for this work. So I do want to touch on these briefly, and then I'll touch on a couple of the pieces of the universal practices briefly. So first off, teaming. The goals of a school mental health team, of course, would be to meet regularly, to use database decision-making, and to think about action planning to support student mental health. So these teams, what you're seeing, these are some of the functions that these teams actually do engage in, everything that's below there. There are lots of different types of teams that we're seeing in our schools, and in fact, this is something that can become quite overwhelming, right? Whether we have a school climate team, our SAP team, our crisis team, our threat assessment team, and the list goes on, PBIS teams, other teams within our multi-tiered frameworks. So the number of teams does get overwhelming, but at the same time, our teams are one of the greatest benefits that we have working in the schools. And so, especially when we think about supporting students with mental health needs, we know that decisions really shouldn't be made by one person in isolation. Our teams are something we really rely on for this work. In terms of needs assessments, we're thinking about using these to assess the needs and strengths within the district or school as they're related to mental health. And so we want to gather well-rounded input. This is really what we see as an important starting point to help identify what the priorities are for moving forward in this work, and also to help advance action planning. There are a lot of tools out there for needs assessment. There's a lot developed by the Center for School Mental Health, a lot of other national organizations, so you don't have to reinvent the wheel on that. But you do want to think about what information it is that you want to gather. In terms of resource mapping, you'll hear me mention this several times throughout the presentation. I will get more into this, but it is so critical in terms of avoiding the duplication of efforts, leveling the playing field in terms of knowing what resources exist, helping to identify gaps in terms of what we don't have available to us now that we want to pursue, and also helping to ensure that the options both within the school setting and also outside in the community are accessible to all students and not solely based on the knowledge of any one individual staff member. That is something that we often see in schools, where someone over here in this building knows of this resource, another person over here might know of that resource. And are those individuals talking to each other? Are they sharing that with others? Community partnerships We want to think about all of the great resources around us as schools. This can be a local children's task force in the county, or even a system of care group that's bringing multiple systems together. And I can share a little bit more about that. It could be local behavioral health agencies, or even something like a United Way or local organization. But these stakeholders bring a lot to our mental health work in schools. They are often very knowledgeable about mental health, suicide prevention, drug and alcohol, trauma, and all of these different issues that are facing our students. And they can really help with the wide range of mental health efforts that we try to put in place, whether it's awareness, whether it's training of staff, whether it's helping to implement student interventions, or even helping to secure grant funding or look at our data. So a lot of benefits in these partnerships. In terms of our policies and procedures, all of our mental health efforts in schools should really circle back and be derived from those policies and procedures. And new practices, as they're being identified, should always have that continuous loop back to see how they fit in and how we may need to modify those procedures moving forward. We always also want to be thinking, and this is sometimes where we see gaps, is how are these procedures being communicated to staff? Are families and youth aware of these policies and procedures? Do they have the opportunity to give input or have voice into those? And then finally, our data-based decision-making, which I'll also be talking about further. But when it has come to our school mental health efforts, these have not always been data-driven. We haven't always looked at the full range of data available to us in schools in order to utilize that within our teams to inform our prevention, intervention, and response efforts. So we will be discussing that a little bit further. For mental health promotion, this really is what we're talking about at the universal level. And there was a prior presentation that I have recorded with Patton that really gets into these pieces a lot more. But I do want to touch on a couple in a little bit more detail. Mental health promotion in general. So this includes the activities that foster the positive social, emotional, and behavioral skills and well-being of all students. And again, this is regardless of whether or not they have an identified mental health need or even at risk for developing mental health problems. These, as you're seeing on the screen, are examples of some of the commonly implemented mental health promotion activities that are an essential piece of the school-wide component or those universal efforts. This doesn't represent a complete list, of course. There are lots of other universal strategies that are important. But I'm going to focus on mental health literacy for a moment. With teacher and school staff well-being, I'm going to turn to that a little bit more toward the end of the presentation. So in thinking about educator training needs that have come out of the pandemic, this is probably something that you as school mental health professionals have been tasked with thinking about. Maybe you've even been responsible for implementing some of this training and professional development. But this is another survey that was done by the Morgan Stanley Alliance for Children's Mental Health. It was also highlighted in that Child Mind Institute report that I had mentioned. And this was looking more so at educator training and resource needs. And what you can see here is that the vast majority of these needs that are being reported by educators are focused around identifying and supporting students with mental health concerns. You also see some feedback in terms of supporting students with who have experienced racial or ethnic discrimination, helping LGBTQ+ students to cope with homophobia or transphobia. So meeting the needs of different populations as well. This is what educators are looking for and asking for at this point in time. What I also find really interesting in looking at this is that, way down on the list toward the bottom is where you see kind of the needs reported around looking at educators' own wellness and self-care and well-being, which, the way that we operate as educators, being the helpers, are often putting ourselves last and often thinking about these things later on. I would argue that even though that is the feedback coming in from educators, that also needs to be right at the top of the list, hand in hand with some of these other trainings, because supporting students with these types of challenges can feel draining and can lead to burnout, especially when staff don't feel totally equipped in doing so. So to talk for a moment about mental health literacy, because I know in the list that I showed you before, these are initiatives that are pretty familiar, school climate initiatives, positive behavioral supports, and things like that. But mental health literacy is slightly different, maybe a little bit new for some of you, but this is really about increasing knowledge and improving attitudes and understanding about mental health disorders to support prevention, recognition, and management of these different conditions. And a huge focus of building mental health literacy is in addressing stigma, it's building awareness, it's helping to debunk myths about mental illness or suicide, teaching signs to increase help seeking and how to respond in terms of having conversations, where to go, other resources available in the community, in the state, or nationally. It's also hugely about normalizing the concept of mental health as something that affects all of us and that we all have to work to maintain. So this is relevant. It's relevant to build mental health literacy across the school setting, with the parent community, and with students as well. It also helps support this layered effort that we've been talking about in terms of identifying a youth that could be experiencing a mental health challenge. So by putting in strategies for mental health literacy, you are effectively building out your safety net within your school community, because you're helping more people to become aware of what to look for and what to do when they see concerns. So these on the screen are just a few different strategies. We're not going to get into all of them. There's some links there that you can explore, but just know that this work is very closely connected to school climate efforts in terms of creating an environment where it's safe to talk about mental health. And people feel comfortable, students feel comfortable talking openly about these things and seeking help. Training, of course, is key. So there's lots of training programs out there. Youth mental health first aid in particular is an example. That's been a big initiative in Pennsylvania. But staying away from once and done and thinking about how do we implement training and then support staff moving forward through coaching opportunities and through reinforcing of some of the skills that are taught in these trainings. We also know that students and families, as you can see from this list, have a huge role in helping to voice their needs and to advocate for what would be helpful to them. So just to briefly point out, the image on this slide is from a PSA contest that we do in Pennsylvania every year for high school students. And that image was created by a high school student in Pennsylvania a few years back. All of these PSA images are available through the Prevent Suicide PA website, and it's using simple awareness modalities like that. We also have video clips and audio clips that you can use within the school setting in partnership with community partners at different events in the community. And these are all free for public use, public access, however you see fit to enhance some of these efforts within your schools. We also, just from a universal standpoint, have been working toward applying the trauma lens within our schools, and especially given the toll of the pandemic. So outside any particular intervention necessarily, the list that you're seeing here are some of those everyday actionable trauma-informed strategies that are trying to reinforce these within our school settings. We also can use these to share with parents for use in the home setting. These are just some of those common strategies that are drawn from the trauma-informed care core values, and also from our crisis literature in terms of how to respond following a crisis, that they can be applied, in kind of the day-to-day, given that we are still navigating this pandemic. These strategies, I will say, tend to work together to cultivate that safe and supportive learning environment. So looking at a couple of these, thinking about providing those structured routines and teaching these, especially if they're new routines. We had that a lot last year, especially as we were coming into the school setting, going into hybrid environments, going virtual, right? Also remaining flexible during these times to identify those teachable moments where things don't go according to plan, and problem solving in real time, being able to model that for our students. We also want to think about offering choice when possible to help students and staff to feel empowered. We know that what works one day might not work the next day. And so again, keeping that flexibility there. But we also at the same time want to set those limits and boundaries to help our students prioritize the same ways that we need to. So personally, I know that I often am asking myself when I'm feeling overwhelmed, what is one thing that I need to focus on right now? Or what is one thing I can focus on right now? We also want to continue to reinforce that language of we in terms of the shared experiences that we are having through this, but also acknowledge that everyone's story is unique and different. And so how can we encourage our students to use their voice and advocate? And then of course, modeling that self-care and self-compassion. We have to get better at that and model that so that our students see that and others around us see that, while also knowing the limitations and boundaries of that so that we know when to reach out or we should be continuously reaching out and then being able to have conversations, express our concern, and know how to make referrals if needed. Just to briefly reinforce one more concept around relationships and connectedness before we turn to talking more about the advanced tiers. I wanted to share this study by Peter Wyman. If you've seen some of my presentations before, I do tend to share this because I found it really, really compelling. Peter Wyman has done work in the field of suicide prevention. He's focused on evaluating some of our strengths-based interventions like sources of strength. And he published this study in 2019 that was one of the first to use relational networking. So nominating of close friends and adults, because he wanted to see how this related to reported suicide attempts from youth. So he conducted this study in 38 different high schools. And the images that you're looking at show the students' nominations of trusted adults comparing two different high schools. So this is really just a snapshot to kind of show you some of the differences in these findings. So if you look at these circles, the students are in the outer ring, and the circles are larger based on the number of nominations that students made. In the middle are the adults, they're in the inner ring, and their circles are larger based on the number of nominations that they received from students. And the darker shaded ones also reflect more nominations that were received. So you can clearly see a difference here. And what the difference is that school D, which is on the left, it's showing several well-identified trusted adults in the middle that were nominated by many students. So you see all of those different lines coming in versus school E on the right, where you're seeing that the trusted adults in the middle have similar numbers of nominations, but they're concentrated among fewer students. And the result in comparing these two schools was that students at school D reported significantly lower suicide attempts than the students at school E. And so the overall finding of this study was that schools had lower suicide attempt rates as reported by students when the identified trusted relationships were more spread out among student populations as opposed to being constrained among a few students or staff, which is really compelling in terms of our efforts to build relationships in our school settings. This was really the first empirical evidence that linked those closer networks, essentially those relationships, to lower reported rates of suicide attempts within high school students. So as we move into the advanced tiers, we will be talking about both early identification and intervention, as well as mental health support and treatment. We won't necessarily be getting into more formalized behavioral health treatment today, other than to just describe some of the partnerships between schools and communities and some considerations for those partnerships more in depth. But our focus will primarily be around the in-school supports for students with more intensive needs, as well as some considerations we'll talk about for staff training and support. But mental health challenges, as we've been talking about, of course, often first emerge at school. So this is a natural setting for the identification and early intervention supports. Having the sound structures and processes in place to do this is critical, because we know that when problems are identified early and supports put in place, this really can mitigate the severity of those future mental health concerns that can be prevented or even reduced in some cases. So for mental health early intervention, we're talking about supporting students who have been identified through a systematic, equitable process as experiencing mild distress, mildly impaired functioning, or is at risk for a given problem or concern. And there are lots of different types of early intervention activities, so our small group interventions for students that may have similar needs. It could be brief individualized interventions, perhaps focused on problem solving or motivational interviewing. It could be mentoring types of programs or low intensity classroom-based supports even, right? And we do know that our tier 2 supports and services may also be appropriate for those students that have more intensive needs, but those students often receive more intensive services in addition to that. And then for mental health support, I probably won't refer to it so much as treatment, right? But that's, so we're kind of talking about both a little bit, but these are the services that address mental health concerns for students who are already experiencing significant distress and impaired functioning. These supports are individualized to specific student needs. So these can be individualized interventions for students that are receiving general or special education, or those who have identified, often diagnosed, but not necessarily social, emotional, or behavioral needs. And some of the options here could be counseling, it could be individual or group, or family therapy as well. And what I will also say is that historically in schools, through our behavior initiatives, there's been a strong emphasis and focus on the externalizing problems, a lot less focus, as I'm sure many of you have seen, on those internalizing problems like anxiety and depression. And as shown in the data and also what you're seeing right in front of you, there have been several calls to action now in terms of increasing the research and increasing our best practice knowledge in these areas within our schools. So the primary areas to be thinking about with regard to this, in terms of the identification of students with a potential mental health need, we want to talk about the approaches that many schools are already using, but I want to offer some areas of growing research and focus that schools may consider building into their current approaches to ensure that these processes are systematic and equitable. Also, while a full review of the individualized and group interventions will be beyond the scope of this presentation, I do want to highlight some evidence-based and best practice interventions today. And I also want to share some resources and considerations for how to identify the interventions that are best suited to your student community. Also, beyond that early identification and intervention, schools do need to plan in advance for individual student, school-wide, and community-level crisis events. Some of our state legislation does mandate that we do this already, but we will talk a bit more about some of the key considerations for planning in advance for these different things. And across all of these areas that you're kind of seeing on the left, which we'll talk through, we do need to be thinking about everything in the box to the right as it leads through all of that. So as mentioned earlier, everything comes down to our teams, their roles, how they function, and all of the efforts that we have in the advanced tiers should have a team planning, decision-making, and monitoring component that we'll talk about. We also, again, need to be thinking about our database decision and also what purpose our documentation serves. So are we gathering our data in a way that's going to make it useful for our teams to utilize? For instance, let me bring up a situation of student crisis. If we're talking about, let's say, a suicide-related crisis, this information does typically get documented, but where is it living? Is it sitting in a file somewhere in someone's office locked up, which it absolutely should be, right? But is there a way that our teams are thinking about also gathering and tracking crisis-related data more systematically so that we can review and use it to look at trends, maybe use it to refine some of our procedures, things like that. And we'll talk about an example of that. Also, how do we monitor our students with mental health challenges in an ongoing way to see if they're making progress? And this can be different than what we've typically done in schools around brief academic or behavioral interventions. Those often will lead to change, measurable change more quickly than some of the mental health treatments and supports that students may be receiving. But it doesn't preclude our ability as teams and as schools to think about how we can monitor progress, even though it may take longer. We also want to think about additional training. Staff may need to do this work. We know we're talking about administrators here. We know we're also talking about all of you as school-based mental health professionals who do play a critical role in implementing and making decisions for many of these students. We know there is variability in terms of how school mental health professionals get trained across specialty areas and also across the different programs that exist. And so we need to be mindful of what additional professional development may be needed in order to support the implementation of interventions, or even to support some of our assessment practices, like conducting a suicide screen or assessment. And then with our community partnerships, of course, again, and you'll hear this will start to sound a little bit like a broken record, but the more supports that are in place and the more effectively these partners can work together in terms of collaborating and communicating, the better the outcome. So again, with partners, I'm using that broadly. I mean the community partners and agencies, and I also mean our families and students. So in about 5 minutes or so, we're probably going to take a brief break, but I want to just go through a couple more things quickly. I'm going to start by talking about that first point around identifying students that may be experiencing a mental health challenge. So as mentioned, our teams are going to be critical in every aspect of creating and maintaining a comprehensive school mental health system, because those teams are going to address multiple aspects of comprehensive school mental health. First and foremost, what we usually think about is that the teams are going to be the ones identifying and addressing the needs of students, whether that's school-wide needs, classroom, or individual approaches. But not only are teams functioning just for that purpose, they're also very much so involved in the infrastructure aspect of all of these efforts. And often when that infrastructure is missing, this is where we see a lot of the issues that tend to really bog us down at work. So things like too many meetings, or duplication, where it seems like we're talking about the same thing in multiple meetings, lack of efficiency, where we could see the same student being discussed in different meetings, or different members of different teams are working on the same thing, or even contradictory things to support a particular student or family without that line of communication. So these are some of those infrastructure related roles and functions that you can see for school mental health teams. First and foremost is the shaping of those policies and procedures, and I'll give you an example of that. So as per Act 18, the requirement for schools to have threat assessment teams, that took effect this school year, and this is to address threat of harm to self or others. Most schools, because of Act 71, already had an established policy or protocol for students that presented with risk of suicidal thoughts or behavior. So now schools are tasked with circling back to think about how the suicide protocols are interfacing with threat assessment teams and the new protocols that are being developed. And school mental health professionals should be involved in both of these procedures, and therefore need to play a role in helping their schools to address some of the potential overlap and the discrepancies that can come up in the process of that. Teams also play a role in identifying the training needs, not just for all staff, like the mental health literacy we talked about, but also for themselves or for other specialized staff. So again, is there a need for additional training in threat assessment or crisis response or trauma in general? Do we need to do this just for the mental health professionals? Do we need to do this for everyone? All of this is important because, again, it's the foundation of people having that basic awareness to help facilitate referrals and identification of student needs. So, and also, what about the interventions that are being implemented? Do staff members need additional training around some of that? Also, the advocacy and grant writing efforts are seeking funding opportunities, of which there have been many coming out of this pandemic. So teams can help play a role in terms of advocating to school boards on the need for more mental health interventions. This also relies on the resource mapping process, right, to identify those gaps and to help drive decisions in terms of needed resources. Teams are also reviewing data and gathering feedback from the school community. So teams might be involved in taking PAYS data and presenting that out to students or to families and soliciting feedback about what the concerns are and their ideas about what would help address some of those concerns, and taking that back to figure out what to do about that. In terms of implementation, this is often where things can get confusing when the roles and functions of teams are not clearly defined. So currently, a lot of schools are looking at their teaming structures, and there's a lot of resources for that I've included on this slide. And they're thinking about engaging in more targeted conversations about how to better align all of these different teams. So some of these resources that you might find helpful, the School Mental Health Quality Guide on Teaming. There's also a resource from the Interconnected Systems Framework of doing a teaming inventory and laying out the different roles and functions, seeing where the overlaps are, seeing where things are duplicative. And then in Pennsylvania specifically, some schools are starting to think about alignment of their staff programs with other teams that are involved in multi-tiered approaches. And a recent document did come out from the state that provides some considerations for that, like the cross-training of team members, also thinking about centralizing a database to really be able to integrate that and use that for decision-making. And then finally, of course, your teams are certainly playing a role in the resource mapping process and identifying key partners in this work. So I am going to pause there just looking at the time because I think we are due for a 15-minute break. Okay, so moving right along, resource mapping, which I have already spoken about, this should be an ongoing and active process to look at both internal and external supports. So this means the interventions and supports that are available within the building or within the district, and also those supports that are available within the community. A lot of the resources are listed in this chart. This chart actually comes from the National Center for School Mental Health, and many of these are especially relevant to our school mental health efforts. But teams, which we've spoken about, will really need this information in order to organize and select and plan and then implement appropriate mental health supports and services. They're also going to need this information to make appropriate referrals that we're going to talk about in a little bit. So for example, if teams are reviewing the PACE data for the district and they're seeing that the district has seen continuous increases in students reporting mental health concerns or possibly even suicidal thoughts and behaviors, or perhaps if teams are reviewing universal screening data and noticing things like 8th grade girls are experiencing concerns with anxiety that seem to be a growing trend. If there are limited universal or small group approaches that are available to address those needs, that's something that would then help to alert those teams to identify appropriate interventions to look and fill that gap. It is also helpful when you're thinking about resource mapping to consider doing so by mapping out the resources at each tier. And so when you do this, what you might end up seeing is that maybe there are a broad range of universal prevention programs that are being implemented in the school, but maybe the school is lacking in specific evidence-based interventions in terms of supporting students that have needs at those advanced tiers. The other thing that could come up, so just as an example, if staffing ratios are good, let's say, so maybe there is an adequate number of school mental health professionals available in the school building, and maybe there is that capacity to offer those small group or individualized supports, but teams start to notice that even though there's the availability of counseling, that it tends to be more based on the background and training of those mental health professionals rather than driven by the needs of the students. And so maybe there's more of a need to look at what evidence-based or evidence-informed interventions could be available and to consider training these staff to be able to implement some of those. The other is that it's a communication tool, of course. So not only are you using this to level the playing field across teams, share with the broader staff, but this could also be a tool that you end up sharing directly with parents and families and with your community partners. This opens up those pathways, especially in sharing resource maps with your parents and families, for them to pursue these options and become more familiar, especially with community resources, but also within school resources on their own, so that they can pursue some of those options and inquire about some of those supports and services if they want to do so. And then also, In doing resource mapping, it's a great opportunity to engage with partners, especially for the pieces of mapping, the supports that are external to the school. This is because a lot of our partners out in the community often are very knowledgeable about what those supports are. And in many cases, county mental health offices or CASP coordinators at the county level, they might already have a lot of this information that's already laid out in different ways. Other partners too, like your staff liaisons, are often very knowledgeable about community resources related to mental health. They often are very knowledgeable about insurance. They know about drug and alcohol crisis resources. So you can call upon these partners in the process of developing your resource maps. And then there also, in the box over there, are some online resource repositories, search engines that you can use for your resource mapping process. Or you can also share these directly with parents, families, and students so that they can identify those community resources on their own. So I want to turn to the referral process. This is a huge part of identifying these students and doing so efficiently and effectively. So when I say referrals, I'm talking about those initial referrals that are coming into the internal school teams. So, when a student first comes to the attention of the school, and also the external referrals for community partners if the student's need might be beyond the scope of the school. So as we go through and we're talking about some of this, just think about the resources and the strategies that would help you to be more efficient in your school mental health referral process, and also in working with your community partners around this. So having an effective and transparent referral process for identifying students is necessary to make sure that students and families are connected to supports in a timely manner. We really want to avoid situations where students are falling through the cracks. And so there's a couple of different approaches to this. Schools can use a direct access model where they make referrals directly to some sort of service that might be outside of the school, or they can utilize a team process where referrals are routed through a multidisciplinary team. Sometimes schools become frustrated with the team process model because sometimes there's a sense that this could be delaying referrals or delaying a needed service. But on the other hand, we've heard feedback that the team process really helps to ensure that options are provided to families. And it also helps improve that communication, that accountability, the use of data to drive these decisions, and to ensure, again, that there's a more well-rounded range of supports being considered, so that ultimately this helps ensure the appropriateness of the referral and the recommendations that come from that. It also helps when we use a team approach in terms of the ongoing monitoring of students and what happens after that referral. And it helps keep some other considerations like 504 and special education considerations on the radar for teams as well. SAMHSA, I want to mention the resource on this slide. SAMHSA has a helpful toolkit resource that's linked here. It has extensive information, a bunch of different sample forms, a lot of tools to help teams look at their referral pathways. And specifically, this visual that you're seeing here is a model that comes out of the toolkit for a self-assessment of referral pathways. So that's to help teams look at the quality of their pathway across 4 different stages. So teams can start by looking at how the school is identifying the student need to begin with. A lot of that comes down to really scrutinizing your teams, as we've been talking about. Then moving on to assess the effectiveness of the referral flow, or how referrals end up getting managed from the point of that initial referral to the resolution of that referral. And then also following that, to look at that mapping of resources that we talked about to know what interventions and supports are available and what do they address in terms of needs. Also, what quality are those interventions? And the last phase is to assess the effectiveness of interventions. So in other words, how do teams know when a student is making improvement? So whatever model we use, or even if we use some combination of these different models, we want to ensure that those who are making the referrals know how to do that. And especially with students and families, that they also know how to self-refer. Our statewide SAP data tells us that a majority of the referrals to SAP, for instance, come from school staff. And we get a lot of feedback coming up from the family community that they often don't know that SAP exists, even though a lot of districts have that information on their website. So just something to be thinking about. Also, As schools are thinking about integrating and aligning their teams, it can be really helpful to engage in a process of creating standard forms, creating unique districts or building level flowcharts or guidelines. So for instance, schools have developed flowcharts that show what types of referrals are routed to which teams, or guidelines for the school community on when to refer a student, like for staff, right? Or training staff on what would be some of the behaviors that would warrant a referral. Some schools have even looked at standard release of information forms across their teams and things like that, looking at even things like referral feedback forms. This is an interesting one where you're actually giving some sort of feedback to the person, the individual who made the referral in the first place, not sharing any confidential information, but acknowledging and validating that they made a referral that is being followed up on. A lot of times I think of those teachers, for example, that refer a student and never hear anything else. And these are staff that care about students just as much as all of us, working on the mental health side. They want to know, is something happening for this student? And it gives them peace of mind and support and reinforces that, they did the right thing in making a referral. Also, just to focus on the direct access model for just a second, in some cases, like in a crisis situation, so for example, if a student is in a crisis related to suicide, schools might want to promote a direct contact with a crisis responder or an emergency room. They can facilitate these warm handoffs, right? As much as possible, we want to help, support this continuity of care in this process. And then finally, we want to be able to identify any barriers in our referral pathways, and also any barriers in terms of either both making the referrals and following through on those referrals by teams or by families. And once we can kind of identify some of those barriers, it really does help us in terms of strengthening our partnerships. So, for example, if families aren't accessing services in the community that they're being referred to, why? Is that a scheduling issue? Is that an insurance issue? Is that particular agency at capacity? Are there other alternative options? So again, this helps to kind of fall back on teams and be able to gather information to make these pathways more effective. As we turn to data use and data sharing, think about where your teams are with some of these questions when it comes to addressing student mental health needs, and also the extent to which your teams are using a structured problem-solving process. So we always want to be using multiple data sources to match mental health related interventions with student needs. And on the next slide, I'm going to share, a little bit more about some of these different sources of data, but it's not just about the sources of data, because often teams are not lacking in the data they have available to them. The challenge is often more about how teams are using that data. So if we're talking about referral procedures, which we just spoke about, what is the data that's being used to identify and refer when there's a potential mental health concern? And then once referrals are made, what additional data then helps substantiate the need for those additional supports? And you can think about your team processes and what data is being brought in those cases. Then when we think about the data to match need to intervention, depending on the need, we want to select appropriate interventions. So this can be where a team process can become a little more difficult. Sometimes teams are much more focused on getting students into an intervention or connected with a support. That ends up being the end goal. And that ends up being where the process stops. And it's especially true in the case of mental health, and especially when referrals are made for outside services or treatment. So we need to think about whether students that are referred for supports and services actually receive those supports and services. And in the cases where those supports are internal to the school, are these interventions being implemented with fidelity, being carried out in accordance with our plan? We might be looking at the number of students referred for supports versus the number of students that receive those supports. And our teams can use that type of data to consider the barriers and also think about problem solving. Another critical piece where we often stop short, especially when referrals are being made to outside providers, but also with the in-school supports is the outcomes, really. And we need to have that data because we need to know if the services may need to be intensified. We need to be able to monitor whether new needs arise and whether concerns are stabilizing or moving in the right direction. And with mental health needs, it often can be a challenge to determine how to best monitor the improvements in functioning, but that does need to be part of the conversation here. So if you think about a group intervention, right, you might be looking at pre-post measures of knowledge or skills to monitor the outcomes there. Or it could be more individualized. So perhaps it's an individualized screening tool that monitors a student's progress, like a depression screener that's being used and implemented in an ongoing manner for a student to look at change over time to graph that out and see those differences. Or if it's a student that's receiving mental health treatment services in the community, but maybe the primary impact that the school was seeing was on their attendance, right? School teams can look and monitor attendance. So that would be like an example of an indicator that would monitor the student's functional improvement at school, even though, you know, we're not necessarily privy to the full information that's happening in treatment. Although again, those collaborations and partnerships can be incredibly helpful to monitoring progress. We then also want to think about data sharing among team members, between teams, and also with our external partners. So we want to think about using data systems that allow for easy data entry, easy data retrieval, and where we can have this centralized to review in one place, while also balancing with confidentiality and privacy. A lot of schools are using an electronic platform to house data and share information. Sometimes they're even folding in some of their electronic forms like consent forms or release of information. But this is where like the policies and protocols come in to make sure that teams are adhering to our federal laws around privacy and confidentiality, resolving issues that come up around HIPAA and FERPA, and making sure information is clearly communicated to parents and families. I can share, I've seen, you know, some consents that try to fold in everything, which, you know, okay, yes, you're getting consent, but then it has like every possible option all on one thing. Like, for example, it has, you know, the initial SAP referral on the same form as any interventions that might be offered following the SAP process or as part of the SAP process, and also has even, you know, consent for referral to outside community supports all on the same form. It's hard for families to kind of truly pick that apart and understand fully what they are consenting for. These are things schools need to be thinking about from the family side of things. In terms of the implications for, you know, that communication and the breaking down of this information, which tends to be a lot for families to understand and navigate. So here's just a snapshot of the data related to school mental health for school teams to be thinking about. And this was pulled from the SAMHSA resource that's linked at the bottom of the screen. So you can go to this and kind of review if you want to look at some of these more closely. But I will say not all of these are direct indicators of student mental health, but they may be ways to identify key risk or protective factors, like through classroom observations or school climate surveys. They also could be useful in terms of measuring how a student's mental health challenge might be impacting their functioning at school, or could be used to monitor progress, kind of like we talked about, attendance records or visits to the nurse's office, for example. That's actually not on this chart. We will also talk about universal mental health screening in just a moment as a growing practice in schools. But what I will say about universal screening, or just screening period, is that it is the most direct way of identifying a student that may be experiencing a mental health challenge. It often will inquire directly from the student or from a variety of informants who are reporting on the range of mental health signs or symptoms or concerns, and then can be taken to a team in the context of other data, like some of these data sources here. So we will touch on universal screening. But first, with everything we've been discussing so far in terms of teams, also the use of data, the referral procedures, the linkages between school and community partners, I do really want to take a moment to highlight the Student Assistance Program in Pennsylvania. mainly because Pennsylvania is very fortunate to have this existing infrastructure. It has been in place for over 30 years, and it's been a collaboration over that time between 3 state agencies. So the Department of Drug and Alcohol Programs, Department of Education, and Department of Human Services, which is where I'm based in the Office of Mental Health and Substance Abuse Services. And SAP, as all of you hopefully know, is required in all Pennsylvania schools for grades K through 12. And it provides this mechanism for early identification, which we've been talking about, and referral, as well as, again, these linkages. One of the strongest aspects of SAP is that it really relies on the connections between schools, families, and community behavioral health partners. The Pennsylvania model for SAP is a systematic process. So as we've been talking about systematic referral pathways, we do have that in place in Pennsylvania, and it has these 4 phases that are outlined here. So referral, team planning, interventions and recommendations, and then follow-up. The SAP process also does include the development of an action plan and implementation of specific strategies and supports. And I want to debunk the myth that SAP is just about getting kids connected with resources external to the school, because it's really about both. Often the students that are referred to SAP need some combination of in-school and community supports. And so it isn't just a pathway for those external resources. And that's something just to really reinforce about the model. It is very dependent upon observable behaviors and data collection at each phase of the process. And SAP teams in schools are supported by mental health, drug and alcohol, or sometimes a combined behavioral health liaison that often has a lot of knowledge of community resources to help facilitate these referrals for students and families. I also want to just underscore that SAP does integrate with multi-tiered frameworks, because while the team process itself that we're talking about tends to fall more in the advanced tiers, teams are often involved in a lot of school-wide awareness efforts and prevention efforts. Also, as you know, what we often hear at the state level, and we completely understand this, but SAP does look very different across the counties, across districts, across building levels. The model, when it's put into practice, really does vary. And that often depends on local resources and local structures that are supporting the model. But one more thing just to reinforce briefly is that our recent legislation, so Act 44 and Act 18, those both do have specific components that focus on SAP. So first and foremost, that SAP should be assessed as part of school safety efforts. And then under Act 18, there's reference to the interface between teams that we've discussed, but in this case, it's SAP and threat assessment teams. So I want to also talk briefly about universal behavioral health screening, especially given the prevalence of mental health concerns and what we've been discussing in terms of average delays from onset to identification. There is a growing movement nationally and in Pennsylvania to think about additional approaches that can support a systematic referral process and more proactively identify youth that might have a mental or behavioral health need. So while this is important to be aware of, and I know a lot of schools have been thinking about this, I do want to give a caution up front that universal behavioral health screening should not be done in isolation. It should be built into multi-tiered structures that have functional teams that have resource mapped and have available resources and have those existing partnerships. That's really, really critical, that infrastructure and readiness piece. So it's not advised to move forward and starting to think about this until those other pieces are addressed. And if they are, then some considerations are listed out here on the slide. And for the sake of time, I'm not going to go into this extensively. This is a really big area of discussion, but you really want to think about what type of tool you're considering using if you want to hone in on a single domain like depression, or go broad and span a bunch of different behavioral health areas. We're always thinking about the psychometric properties in terms of how the measure might have been validated, its sensitivity and specificity. We want to look at readability, who this tool was validated on in terms of the norming group and different things like that. Who is it appropriate for, the language levels, all of that. And then work through all of the logistical considerations, the technology aspect of it, But at the end of the day, I've often worked with schools that struggle to identify the right tool for them. A lot of this comes down to what do you want to know and how do you plan to use this measure? So that can really inform this. How is it going to enhance the data that you already have? Where are the gaps in the data you're getting and how can that inform this decision? And then that's just a snapshot of a wide range of measures that are appropriate or have been used in universal screening efforts. Similar here, just a few other considerations, things like making sure this is a top-down approach and this is supported by leadership. I've also often had conversations. One of the challenging aspects of planning for universal screening is in looking at the pathways, especially if you're using a broad-based tool that's going to come out with a bunch of different potential concerns. You want to think about how are you making decisions from there, the decisions tree, so to speak. So are you routing these to teams? Do you have a protocol to address the imminent concerns that might be time sensitive? How are you going to communicate about the results and document this for the school? But we also want to also think about that we're not using these measures for diagnosis. We're not using this for direct referral to treatment necessarily, that this is one measure at one time point and needs to be considered in the context of other data. So most schools that have worked on this have planned for this from anywhere from 3 months to 9 months, a whole school year sometimes, to really get ready. And the best results have sometimes been seen when schools do start small and not dive into this too haphazardly or too quickly. One brief study that I want to highlight related to universal screening comes right from Pennsylvania. This was focused on Pennsylvania schools, and the referral pathways in the study actually utilized the SAP program. It was a study done by Penn State. 14 high schools were involved, almost 13,000 students, and they spanned rural, urban, and suburban settings. And what happened was that students were randomized. It was a randomized control study. Students were randomized by grade to either the control group was just current school processes of regular referrals to SAP as usual throughout the school year, versus the intervention, which was a universal screening of the PHQ-9, a depression screener. And students were basically followed over the course of the year to see whether universal screening helped to increase referrals and identification of youth that are at risk of major depressive disorder, and whether it subsequently increased linkage and access to treatment. But treatment was defined by the 4092 forms, for the PDE 4092 forms, which could be either a school or community service. So the study, what it found, what you're looking at in this graphic, is that students that screened positive on the PHQ-9 ended up having 6 times the odds of being identified and referred to SAP in the first place. So again, we know that there's challenges around catching those students with internalizing concerns. Ultimately, those students had 2 times higher odds of accessing a recommended treatment or service when compared to their peers that were not part of the universal screening efforts. So I do want to turn to examples of mental health interventions and supports. I will give the caveat that this is not an exhaustive list. Just provides a snapshot. And I know a question had come in to the chat earlier about examples. So here they are. Really, again, as is not surprising, I've kind of mentioned this several times, most of the school-based interventions that have been more widely researched in the literature have been more focused on externalizing behaviors. So there is a limited evidence base in terms of the interventions for internalizing problems, especially in looking at the supports that might be implemented at the advanced tiers. Not all of these that you're looking at even here have been evaluated through our gold standard of an RCT. Some have been evaluated through more quasi-experimental designs or even single case design studies. One I can pick out, for example, is the Courage and Confidence Mentor Program. That looked at internalizing problems and is actually a modified version of check and check out. It was evaluated through single case studies, but was able to see reductions in terms of internalizing problems measured by self-report ratings and also by teacher reports. I will also say, even for universal interventions, which aren't really reflected here, there is still a limited evidence base. So that is still growing, even for suicide, for example, which is a field I work in a lot. There's really only one suicide prevention universal education program, Signs of Suicide, that has been extensively studied and replicated to be able to show positive outcomes in terms of significantly lower suicidal thoughts and attempts. But some of our other universal approaches, and I'll give the example of the good behavior game, those address those early behavioral skills, pro-social behaviors, and still have had outcomes when looked at longitudinally on some of these mental health related indicators, including suicide. So it's kind of difficult at times to navigate through the literature on some of this. I will also say about this list, a lot of these tend to have more of a cognitive behavioral orientation. That's been found and pulled out from meta-analyses and systematic reviews. A lot of these, of course, tend to be at the middle and high school level as opposed to the elementary level. But some of these are designed to be implemented across the tiers. And I will pull out one in a moment, DBT Steps A, just because, you know, it's interesting in terms of how it is looked at as a universal intervention that is built upon as we go up in the tiers, adding different intervention components or increasing in terms of the intensity of the intervention. The other thing to also mention, and this has come out of some meta-analyses as well, is that there is often a family component that has been found to be a significant component of efficacy from some of the studies of some of these interventions. So things like family school communication, when that is an intervention component, family school collaboration, there's parent behavior support or something that is promoting more positive relationships between parents and teachers. Those, when they've been built into some of these interventions that are designed mostly to be implemented with students, have been a significant factor in terms of the outcomes that are being seen. So just another consideration there. Ultimately, when you are seeking mental health related interventions, it's important to look at the research in terms of what has been established. Given some of the limitations just discussed, it can also be helpful to even look to things that are evidence informed or have emerging evidence as a promising practice. And it's also very important to consider if how the intervention is aligned with the cultural and linguistic backgrounds of students and their families. So one resource that I really want to highlight is the Mental Health Technology Transfer Center. You see that under the second bullet point. They have started a best and promising practices library where they actually break down an intervention into individual fact sheets and talk about how it's delivered, what adaptations can be made to the intervention, what materials are needed, what populations it's appropriate for or not appropriate for, whether there's an existing fidelity tool to help monitor fidelity and a lot of other things. They do currently have these documents created. They have 9, so it's still a growing initiative, but the 9 that they already have on there do represent very diverse approaches. They do also represent diverse types of needs, externalizing, internalizing, and also different populations are also reflected in what they've compiled so far. So I would encourage people to take a look at that. Briefly to touch on DBT Steps A that I had mentioned, this would be an example of a school-based intervention with research that is still emerging. However, the skills that are embedded within this intervention are grounded in a very, very well-researched and evidence-based therapeutic technique, of course, which many of you know, dialectical behavior therapy. And that was originally developed for adults. It was adapted first for adolescents that were at risk of suicide, but it is, DBT in general with adolescents is very comprehensive. The therapeutic approach has a lot of different components to it. There is an RCT cited by Mellum in 2014 that found that adolescents that received this treatment approach versus usual care had significant reductions in self-harm, depression, hopelessness, and borderline personality symptoms after 16 weeks of treatment. And what this intervention did is Dr. Jim Mazza, a school psychologist, worked with his wife, Dr. Elizabeth Mazza, a clinical psychologist who trained under Marsha Linehan, to adapt and extract the DBT skills from therapy to be fitting for school settings. And so they've created this curriculum book. They have online videos, but they really are looking at these DBT skills: mindfulness, distress tolerance, emotion regulation, and interpersonal effectiveness as these basic social emotional life skills that are appropriate for a universal intervention and then can be layered to provide more intensive instruction, coaching, practice with feedback in group or individualized settings. And another positive is that the language of DBT is often used in treatment outside of schools, so it helps create that common language and support students that are in schools and receiving services, or even perhaps transitioning between placements. I want to talk also more about community partners in terms of all of the supports that they can provide across the continuum. And mainly what I want to highlight here, and for the sake of time also, is thinking about these letters of agreements or memorandums of understanding that do get developed. There's a resource that kind of breaks down what's typically in an MOU, but even outside of the MOU, because that tends to be, I don't want to say bare bones, but it has all of the key pieces. But I think what's more important sometimes with these partners are the conversations that are happening around the development of an MOU, and to be thinking about all of these other considerations, and just knowing that, especially when you have a community partner coming into the school, they're often operating under different laws and guidelines than what we're operating under in the schools. And that can lead to a lot of misunderstanding and a lot of conflict. So thinking about the referrals and accessing services, you want to talk about what are the pathways? How are students going to access this service that may or may not be implemented within the school setting? Are they going to go through an existing school team process? Can direct referrals be made? Things like that. As far as service delivery, you want to think about laying out what are all of the services? Where are these going to be delivered? Are parents and families going to be involved, and to what degree? Because that's often also something that can come up, especially knowing some of our mental health laws for students that are 14 and above. How is the communication going to be bridged in those cases, especially if services are being delivered in the school setting? With confidentiality and consent, that aligns with what I was just talking about, but navigating both HIPAA and FERPA can be a challenge, but really should not be an insurmountable obstacle for these partnerships. So coming together, talking about the differences, talking about the barriers, and coming up with a plan, being able to have that up front can really reduce the likelihood that there are going to be issues that arise. With communication, you want to make sure you know points of contact. You want to know how the information about the services and how to make a referral is going to be shared out. And again, is this something that parents and students can access on their own if they want to, or does everything need to be routed somewhere? And finally, just to consider processes for conflict resolution if issues do arise. And again, a lot of this ends up revolving around the laws and regulations between the systems. We do also know that students have better outcomes in school and mental health treatment when their families are involved. So I just want to really underscore the importance of this. And when families aren't involved, we know that that can adversely affect the outcomes, but we often have this deficit mentality in our schools that we're the experts and we need to see the families as that instead. We know that family voice and choice is a huge part of our mental health system. It's part of our system of care work that's been in place in Pennsylvania for a very long time. And these systems still operate at the county level. They're all focused on empowering youth and families to be equal partners in local planning and a voice in their own services and supports. And so we want to bring that mentality and that spirit into the schools around these conversations as well. We also want to acknowledge that we have to approach these conversations with cultural humility. There is a lot of stigma. There are a lot of barriers around talking about mental health and needed services. And we need to understand where families are at with some of these things. That's where a lot of our awareness efforts can come into play. And again, partnerships around all of these things that we can be doing out in the community. The resources that I want to share on this slide are a lot of Pennsylvania specific organizations that have done great work and have free resources to support parents in learning about difficult topics, to support student-led awareness efforts in schools. The PA Parent and Family Alliance has taken some of our challenging mental health laws, Act 65, around student or youth consent for treatment, and broken that down into a parent-friendly tip sheet. They also have a service for parents that's a family support partner that's free to help families that are navigating finding supports for their student that has a mental health need. So all of these are great resources as well. When it comes down to risk assessment, risk screening, schools are making a lot of decisions about this. This should already be embedded into schools' protocols. And they're deciding whether they're going to do a screen or a more in-depth assessment. As I mentioned earlier, now with Act 18, schools are thinking about how these procedures interface with their threat assessment teams and protocols. But ultimately, schools must have methods for identification of students at risk of suicide in their policies. There are a lot of examples of different screening and assessment tools that are out there. These are just some of them. But really, one of the main things to be mindful of is that, are you doing a screening or assessment? If you're doing either way, regardless, you want to make sure you're thinking about a measure that's going to bring consistency to the process. You don't want it to be a situation where with different students in different situations, different questions are being asked, or between two different staff members in the school, each one is using a different measure, right? So to build up the consistency and also to support staff in these difficult situations of making these decisions that can feel very high stakes, having consistency and selecting a tool and making sure staff have the appropriate training on that tool and know what the follow-up steps are for decision-making is a key piece of this process. As far as individualized interventions, again, it's all a lot to fold into a 2-hour presentation, but know that safety planning is one evidence-based intervention that is designed and evidence-based to support individuals with suicidal thoughts and behaviors. There are lots of variations of a safety planning tool, but essentially what this is trying to do is help build out the internal and external coping strategies for a student that's experiencing. It really is designed for suicidal crises, but could even apply for a non-suicidal self-injury or other mental health crisis that a student might be experiencing. It's a hierarchical set of activities that students can use so that they're building up their own capacity to be able to navigate the emotions and feelings that they're having and be able to kind of come back down from that moment of crisis. It starts and again is developed collaboratively with a student using their own language whenever possible by having students articulate what is it that are your own warning signs or your own triggers that you notice if you're starting to feel distressed and writing that out. So whether it's a feeling, whether it's a thought, whether it's a behavior. And then moving up from there. So if you experience those feelings or thoughts, what are some ways that you can try to distract yourself? Just simple distraction, right? Taking a walk, listening to music. If that doesn't work, where can you go to be in a more social setting so that you can also add to that distraction and be around people, be not so isolated? Whether it's a library, a lunchroom, a coffee shop, just a social environment. You're not yet having conversations about what's going on, but just again, trying to distract yourself. From there, it is about identifying trusted adults. So who can I talk to that is a natural support, someone that I rely on and trust that I can have a conversation with? If that doesn't help or if that doesn't work, then it gets into crisis resources and supports. And this is something that should be shared collaboratively, especially with the individuals that are in the safety plan, especially with families, because as a piece of this, you're wanting to also work on keeping environments safe. So if a student may have a plan in mind or a particular method, you want to be looking at supporting families within the home environment to make sure that that isn't accessible to that child, even if it just means temporarily removing something from the home, locking something up. And there are resources because as school mental health professionals, we often don't get trained in how to navigate some of these difficult conversations. So there are resources on, and all of these are free in terms of templates and trainings online. Just for the sake of time, I'm probably going to skip through this quickly. I had mentioned before this idea of tracking crisis situations. So this is just a snapshot. You have this in the slides in terms of what types of information could be tracked and how teams could then use this information to have discussions about ways to improve their processes and procedures. So one thing I hear a lot is that schools are often making referrals external to the school when there's a crisis. I referred the student to the emergency room or to crisis, but they were back in school the next day. Being able to actually look at the data to see how frequently is this happening can give the team some very helpful information to identify additional training needs, to identify partners that it might be helpful to have a conversation with in terms of, for an emergency department staff or a crisis worker, what are their procedures? How do they make those determinations? Could they share information back with the school that can help improve that communication and improve those referral pathways? Or can they themselves maybe offer training to help school staff in terms of trying to address an issue such as that? It's also important to think about once a student is hospitalized or is in some sort of out of school placement, that schools need to be thinking about a systematic approach to supporting a student upon reentry to school. A lot of times the family doesn't necessarily see the schools as playing a role in supporting their child's mental health, and those outside systems partners don't see what schools could be doing or how they could be supporting the child when they return. But as you all know, there are many, many ways that schools can support these students. And so a lot of this piece is about establishing those procedures, again, forging those partnerships, but also being able to have a specific template for a reentry plan and to try to make this standard practice. We don't always get the information we need, but regardless of what comes back to us as a school, can we make this part of our standard procedures to have a reentry meeting and try to work with students and families to identify how could we support them? This isn't a long-term support, but this is often a shorter-term temporary support to ease this transition so that a student can be successfully reacclimated into the school environment. A lot of times the first thinking is to go immediately to some sort of more intensive evaluation process. That also needs to be on the team's radar, but may not necessarily be the first step in all cases. So again, this is where having those protocols takes place. And these are just some of the considerations for a reentry meeting and plan in terms of what the student feels comfortable sharing with others in the school environment, if they may need help to do some of that, and also what specific accommodations can be put in place in the short term, whether it's reducing workload, trying to adjust some of the makeup work that was missed, trying to have check-ins with a staff member, or have a place for the student to go if they start to feel overwhelmed. There are resources being developed as well at the state level now to support reentry. It is an important component of this continuum. Moving into crisis response, the School Crisis Recovery and Renewal Project is a partner with the National Child Traumatic Stress Network, and they actually highlighted the importance of student voice in crisis recovery and worked on gathering some feedback through focus groups with students to create these infographics. And I won't go into detail here now, but as you can see, students shared information about what has helped them. This was young adults that experienced a school crisis at the time that they were school age, and they gave this feedback in terms of what was helpful and what felt harmful or hurt. And so you can all kind of go back and revisit this to take a closer look. But one of the biggest things that you said as part of that project was that what can absolutely cause harm following a crisis is neglect, or this idea that the crisis will somehow resolve itself when there isn't any little to no response or acknowledgement from the school. And that's absolutely not the case. We know that crisis response is a huge piece of the prevention continuum. A carefully planned and organized crisis response can mitigate that traumatic impact on the school community, whatever the crisis may be. So usually in responding to a tragic loss, especially if it's a death of a student or staff member, a death by suicide, we sometimes call that postvention. So you kind of see both of those terms here. The goals are in supporting those that are grieving the loss of the classmate or teacher or colleague, returning the school to its new normal routines as quickly as possible, being able to identify and refer individuals that are at risk for unhealthy behaviors or unhealthy coping and reactions. And then in the case of suicide in particular, reducing the risk of contagion. That's critical. So that's how this fits into prevention, right? You're preventing further crisis situations or perhaps suicidal behavior or even suicide deaths. So these are all of those key considerations for planning ahead for crisis response, which is really what you want your teams to be doing. There's a lot of different pieces from, again, having these interagency agreements, having thoroughly and carefully thought out communication plans for internal and external to the school, seeing how your approaches fit into an overarching framework. I'll talk briefly about Prepare in just a moment. Thinking about, we know that we haven't had full research on crisis response or postvention because there's so many different components to evaluate, but the strategies and supports used within the context of crisis response or postvention should be grounded in research or evidence-based, like using a validated screening tool or implementing a certain intervention or using safety planning, for example, like we just talked about. We also want to make sure there's policies in place for memorials, and that you're thinking about following up, and whenever a crisis unfortunately does occur, to also see what opportunity that brings in terms of refining these procedures in the future, and lots of resources for this work as well. Prepare is just one model and framework for crisis response. It is broad in scope and applicable to any type of school crisis, whether that's minimal level all the way up to a massive community level event. And Prepare was designed by educators for educators. So it really takes into account the unique context of the school setting, but it also works to very carefully align crisis response protocols with federal organizations and federal protocols and language that is used for crisis response, because we know that schools will often need those external supports to come in, and Prepare helps break down some of the barriers there in terms of that communication and the process there. It has a planning aspect to it of helping teams to pre-plan for crisis, as we talked about. And then it also has a follow-up in terms of what additional mental health training do the school mental health professionals and their community partners need to respond and help the school community recover following a crisis, and what are the continuum of supports that are available. And I selected Prepare in part because, again, it uses that multi-tiered framework. So just constantly reinforcing these supports and how they work across the tiers of intervention. These are some resources for grief and loss. I just compiled everything, so it's something that you can refer to as you need it, probably at a later date and time. And what I really just kind of want to end with is highlighting this importance of educator resilience, well-being, and self-care. This is really critical work, and it is really exhausting work. And so this is something that schools really need to be thinking about in terms of finding ways to help educators assess their well-being and self-care, and also being mindful of supports that can be implemented for individuals as well as at the organizational level to try to create this more supportive culture that is being mindful of what educators are doing right now and what they always have been doing and what they will continue to do. There are some resources that I want to highlight because they're not once and done. I'll talk about the Compassion Resilience Toolkit more in just a moment, but here's also a snapshot just for your reference. If you come back to these slides, you can certainly access any of these tools. On the right are some of the evidence-based intervention approaches that have been looked at with an educator sample. But essentially what compassion resilience is, this work came out of Wisconsin and a toolkit was developed, but this is the ability to maintain our physical, emotional, and mental well-being while we're responding compassionately and with empathy to youth, especially when those youth have experienced trauma or have undergone times that are particularly challenging. And in this toolkit, which is designed, it's free and accessible online, it's designed to be implemented in schools, but there's also a social services version and there's a version for families. But it helps us to think through, expectations in terms of ones we've set for ourselves and others. Are they realistic? Setting boundaries, creating a culture that is compassionate, and being mindful of our own self-care in a very well-rounded and comprehensive way with these 4 components. Those 4 components play out as well in the wellness compass within this compassion resilience toolkit, where all of these pieces are kind of laid out with assessment tools, and then there's a lot of interactive activities that either you as a school mental health professional can use and facilitate this with staff, or you could also potentially be part of this, but it's designed to unfold over time, over a period of up to 2 years, with all of the agendas, activities, resources that are laid out there. And just helping individuals to reflect on their individual self-care and helping organizations to think about what could we be doing better to help reinforce and build compassion resilience in our staff. As another brief resource, you heard me talk several times about the Center for School Mental Health, and they have a free system, their school health assessment and performance evaluation system, which provides an opportunity for schools to go in and access a wide range of tools to really evaluate this infrastructure for comprehensive school mental health. And then in addition to that, they have a bunch of quality guides. So if you decide you want to target on a certain area, there's a lot of guidance for that. There's training and assessment libraries. There's a lot of resources for you to continue to engage in this work within your own settings. And then the Suicide Prevention Online Learning Center is a free training site. I know I've given quite a few examples of suicide prevention resources throughout today, but this is where you can access additional training. So there's training for educators in general, and there's also new facilitator guides. So you as a school mental health professional could access this guide and use it to facilitate an interactive training with your staff. Everything's created for you. There's also trainings that might be more appropriate and geared toward you as a mental health professional in terms of screening, assessment, safety planning. And we continue to build in new topics. There was a training recently added on supporting adolescents that are engaging in non-suicidal self-injury. There's one on concussions and risk of depression and suicide and the linkages there. So a lot of resources and trainings are available there. And then finally, just to highlight crisis resources, these are available state level, also nationally, and the vast majority of these, except for our SAP process, which isn't so much a crisis resource, but everything else on here is free, available 24/7, and confidential. These are great resources to share with your school communities. And just a few other resources, and then my contact information. So I just want to thank everyone. I apologize. I know I didn't leave a ton of time for questions, but I'm hoping that we can get to a few.